What is psychiatric mental health nursing? Basically, it's a philosophy of care and set of skills we use in the psychiatric setting that can be applied in many different clinical situations. Psychiatric units are specialized, safe, therapeutic settings where patients can be monitored and treated. Skills used by nurses in these settings include determining what safety precautions need to be implemented, conducting a psychosocial assessment, which you'll learn about from Professor Brandt, and creating a therapeutic relationship and environment. We hope that even if you do not plan to work in psych, that you learn and use these skills. You will meet patients in the hospital who have diagnosed or undiagnosed mental health disorders. The ability to calm and connect with an agitated patient is invaluable. Right now, at one hospital, they're moving individuals who have been Baker acted to rooms on med-surg floors because of COVID. Those affected by mental health disorders make up 20% of the population. They're going to end up on your floors. During this course, we will explain what leads to mental illness, how people are affected, and what treatments are available. Let's begin our introduction to psych by talking about a young man I admitted at the end of my shift one night on the child adolescent unit. His story captures many important aspects of psychiatric nursing. He was 17, cooperated with the admission assessment, and admitted to feeling down lately. When I asked if he had suicidal thoughts, he said, "Well, no." Most adolescents would answer yes or no. His ambivalence, the questioning in his response when he said no, alarmed me. I asked staff to watch the patient carefully and went in to report. I shared my assessment with the night nurse. The night nurse and I initiated closer observation of the patient after we discussed my observation. The night mental health tech rounded on the patient throughout the night. In the middle of the night, the patient was found trying to get to the wiring in the room to electrocute himself. Today, the units have electrical wiring more securely locked away. Patient monitoring is standardized. It's not just done at the nurse's discretion. Suicide assessments are more standardized. That's just a glimpse of what psychiatric nurses do. We will go into more of the role of the nurse as we proceed through the presentation and as you go through the course. Welcome to the Introduction to Psychiatric Nursing, Part 2. Let's discuss the hospital intercollaborative team members and some of their functions. Patients will initially be assessed by intake staff, who might be licensed mental health counselors, social workers, or nurses. Patients who arrive under a Baker Act will go directly to the unit. Other patients will require further evaluation to determine if inpatient admission is necessary. The decision will be made in collaboration with the psychiatrist and be based on patient safety in the community. Once admitted, the psychiatrist will assess the patient and create a diagnosis based on the DSM-5. DSM-5 is short for the Diagnostic and Statistical Manual of Mental Illness version 5. The DSM-5 provides descriptions of the disorders, statistics, and consensus criteria patients need to meet for psychiatric diagnoses. Pharmacological treatment and legal status will be modified based on the patient's daily progress and determined by the psychiatrist. Case managers help patients make plans for after discharge. They may also help to contact family members. They'll determine who would be the legal guardian for the patient, and they'll arrange for further Baker Act proceedings. Licensed mental health counselors may provide group therapy or assist with case management, and case managers and licensed mental health counselors can do these jobs interchangeably. So what I said case managers can do, licensed mental health counselors can do, and what I said, and vice versa. Recreational therapists provide relaxation activities and help patients learn coping strategies. Most units have treatment team meetings Monday through Friday to create goals, monitor progress, and plan follow-up treatment for the patient. Ideally, at least one nurse sits in the treatment team meeting to report nursing concerns, advocate as necessary, and help the team focus on care plan goals. Patients are often brought into these meetings. One of the things I first assess when I take students out to clinical sites is the therapeutic milieu or therapeutic environment. According to your text, milieu therapy is a supportive environment in which clinicians and staff work with patients to provide safety and structure while assessing the patient's relationships and behaviors. Components of milieu therapy include, first of all, a consistent routine. When meals, phone calls, and visitation in groups occur at the same time every day, the patient knows what to expect. The environment becomes more predictable. Another important component is structure. Some treatment units create structure by having a consistent approach to similar situations. Some places provide structure by keeping activities planned throughout the day for the patients. Other places provide structure by encouraging patient responsibility for part of their care, like having patients call places that they have been referred to. A third component exists when staff role model therapeutic, effective, and/or assertive communication and provide patients with opportunities to practice their communication skills. The ANA more specifically emphasizes the following as being part of the nurse's role in maintaining a therapeutic milieu. First, the ANA suggests orient the patient to their rights and responsibilities in the treatment environment. We could make sure they understand they have a right to informed consent. We may need to help them write down questions they have about medications or communicate those questions to the treatment team. Second, the ANA suggests that we assist consumers to select and participate in meaningful treatment and activities that promote their personal growth. We can point out which groups are most valuable or what they might learn from specific groups. Third, the ANA suggests we advocate for the least restrictive measures to maintain safety individually and collectively within the milieu. We could speak up and offer a less intrusive strategy than seclusion when or if other staff members suggest this option. Groups differ by types. One specific type is a processing group. Processing groups vary in structure based on the techniques and approach used by the therapist and the counseling theories that support the foundation of their therapy. ASN and BSN degree nurses can conduct 3 types of groups. They do not conduct processing groups. What do I mean by processing? I mean that you start exploring and going deeper into the source of what leads to an individual's distress, and you have a plan to help the person as they re-experience these feelings. Here's an example of processing that might occur in a group. In a PTSD group, the therapist pointed out that he recognized that many of the vets were triggered when they heard the helicopters coming around Shands in the VA, the Vietnam vets particularly. He pointed out that the helicopters were a different model than those used in Vietnam. He was using cognitive behavioral therapy and empathizing with the veterans. And his goal was to help them to see the helicopters in a different way and to start making different associations when they heard that sound. What types of groups can ASN and BSN nurses provide? Nurses can organize recreational groups, have patients play games or music and get all the patients involved. Nurses can deliver educational groups on topics such as medications, the addiction process, and assertiveness strategies. In addition, they can provide supportive groups. Imagine the nurse recognizes that patients have become upset because of recent activities on the unit. He or she can gather the patients to facilitate sharing their concerns, which helps them focus on actions they can take for themselves. Psychiatric nurse practitioners, master's level social workers, and psychologists provide counseling or processing groups. These groups are based on a specific evidence-based counseling theory. For example, at the VA, the therapists also deliver groups on mindfulness, which is based on dialectical behavior therapy. Typically, therapists introduce topics or techniques and then encourage patients to participate in discussion or apply the technique. Skills needed by the therapist include both the ability to encourage patient discussion and the ability to handle challenging patients. We will have patients who talk continuously, not always on topic, and others who are hesitant to participate. Yet our goal is for each person to have some time to talk and do some processing. Safety on inpatient units starts before the patient arrives with the design of the units. We have chairs now that are too heavy to be thrown. Most of us can barely push the chairs on the unit when I go out to clinicals with students, and I can push things that are pretty heavy. We don't use plastic bags on the unit. They can be used to self-asphyxiate. Bathrooms and rooms are designed to have no ligature points. This means there are no places from which to tie something to hang oneself with. We can't even use alcohol out on the units. Patients know to put salt in the bottle, and that after they do this, a drinkable solution will result. They found patients passed out in the stairwells after drinking this solution and have had to admit these patients to the ICU. We also check to make sure patients do not bring items on the unit that they can use to harm themselves. We check what is on their person and check their belongings. The hospital will have a list of what are considered potentially unsafe objects or contraband. Many hospitals check for contraband twice a day. Units limit what visitors may bring on the unit and ask that students adhere to their policies. Contraband could include belts, drawstrings from pants, shoestrings, shampoo, pens, cell phones. Why cell phones? They could take pictures of other patients, which is a HIPAA violation, or turn the cell phone into a weapon. Nurses use their clinical judgment and limit access to anything patients could use to harm themselves. Safety can also be enhanced by increased awareness of your patient's location, mood, and behavior. A nurse who is on the unit can detect that a patient seems more upset than usual, or that two people keep making threats to each other when they pass in the hallway. Most units locally check their patients every 15 minutes. This is best practice, yet not standard across the country. You may see additional degrees of observation, such as one-to-one or eye contact. One-to-one means one staff member is dedicated to that patient. Minimal evidence exists to support use of eye contact. It is not being used as frequently today. More evidence exists to supporting use of engagement strategies now. Safety continues with milieu management, which consists of knowing how the staff are interacting with the patients, how the patients are interacting with each other, and knowing our individual patients. You can start with learning about your patient. Do they have a history of psychosis, homicidal ideation, suicidal ideation, aggressive tendencies, or trying to leave the facility? Even if a patient has this history, we can build trust with them, and that's where we start. Most psych patients are tired of being isolated and stigmatized. They want to connect. Start by building rapport. Next, be vigilant for patients becoming upset. Listen, try to figure out what might be agitating your patient and attend to what the patient needs. You may need to decrease the level of noise on the unit or create a more soothing atmosphere by providing music. Finally, consider how other staff members' behaviors might affect the patients. Today, in mental health, staff education is focused on early crisis intervention. Staff learn to intervene in a way that's less likely to aggravate or escalate the patient. You might see a nurse in the clinical setting go up to a patient who started to raise their voice, bring up a different topic while guiding them away from the other person and using a calm tone of voice. You might see staff assignments shift if a patient becomes agitated around a staff member. In a healthy environment, you will see staff talking about how their communication works or does not work with patients. When nurses engage with their patients or spend more time with them, both the nurse and the patient benefit. The nurse can gather most of the assessment information and build trust with one or a group of patients. The patients will be focused on the activity and less likely to become upset about other things on the unit. Nurses can engage with patients through daily conversations, one-to-one interviews with patients, offering a group activity, or encouraging patients to join planned activities. Here's a question. How would you answer this? Be prepared to discuss this situation in class on Monday. You will complete this activity in class on Monday. Please be sure to have the Baker Act handout accessible. Read it ahead of time. We will be going through the answers to the questions in the back of that handout on Monday. The Baker Act is rather complex and the answers may not be as straightforward as you might think. One legal term you will want to understand is least restrictive environment. This applies to patients' rights in two situations: where they are placed and how much we restrict their freedom when we try to control their behavior. When patients are evaluated in the community, therapists, nurse practitioners, and psychiatrists or physicians will assess patients and decide if they can be safely treated as an outpatient using therapy or medication. Those who are not a danger to themselves will be treated outpatient in the least restrictive environment. If a person's behavior escalates and a nurse uses distraction instead of restraints, the nurse is providing a less restrictive environment. What do you think a more restrictive environment or intervention would be? What do you think the experience of restraints is like for patients? Watch this video from the United Kingdom. Focus on the segment from between 45 seconds to 2 minutes and 50 seconds. We have not used face-down restraints in the U.S. for several years. Patients may, however, be held prone while they are prepared to be placed in restraints. Many psychiatric nurses are trying to safely reduce the number of seclusion and restraint episodes. The Joint Commission assesses organizational use of restraints when they visit. Restraint and seclusion use is one of the benchmarks used for NDN-QA, or the National Database of Nursing Quality Assurance Indicators. Facilities which do the best job of reducing restraints first of all have leadership teams which meet with staff after events, listen, and help problem solve how to work with the patient or with the patient issues. Second, these facilities use information or data. They look at what time of day the events occur, what was happening, and note, like in one situation, we noted that patients were more agitated after hearing their Baker Acts were extended. Management increased security after court was let out. Third, they developed the workforce. Before I even went back to Shanzi UF Psychiatric Hospital, they had implemented a plan to teach staff how to use verbal de-escalation, and this was done according to the Crisis Prevention Institute's model. Fourth, organizations use seclusion and restraint reduction tools. An example of this is use of safety plans or comfort rooms. Fifth, they involve consumers. Many places use peer support specialists. Sixth, successful organizations debrief with both staff and the patient to discuss what led to the event, actions taken, and how staff and the patient might handle the situation differently the next time. In conclusion, I have seen tremendous growth in patient advocacy and the use of evidence-based practice since I've been a psychiatric nurse. First, we have our own American Psychiatric Nurses Association Standards of Care. Here are a few of their recommendations based on those standards. When we interview, we want to be mindful of our use of therapeutic communication. Are we building a therapeutic relationship? For example, instead of asking, "Are you depressed?" we can ask, "What's your mood like today?" When planning care, safety comes first. Intervention and nursing diagnoses which address risk of self-injury or risk of injury to others take priority. Act on those first. Let the patient participate in the creation of their goals. We also need to know Joint Commission standards that affect psychiatric patient care. According to the Joint Commission, we need to screen all patients for suicide risk and follow stricter standards for length of the order and monitoring for patients in restraints and seclusion. The physician must come to the facility within an hour to assess the patient or to renew any order for restraints. And the order for restraints is only good for an hour for children under age 9, for 2 hours for those aged 9 to 18, and for 4 hours for anyone 18 or older. This has just been a brief introduction into psychiatric mental health nursing. You will learn more about how we practice and the specific disorders throughout the course. Be sure to come to class prepared as we will be practicing skills, going through questions, and completing a Baker Act activity. See the Canvas page for details. Also, please post questions on the discussion board. Those questions you post help me to be better prepared in how I deliver the lecture. It helps me to see what you don't understand so that I can present that information more clearly the next time. Thank you. I appreciate your time, and see you in class on Monday. Feel ready to go on a psychiatric ward? I'm kidding. We will be doing virtual clinicals anyway. This has just been a brief introduction into psychiatric mental health nursing. You will learn more about how we practice and the specific disorders throughout the course. Be sure to come to class prepared as we will be practicing skills, going through questions, and completing a Baker Act activity. See the Canvas page for details. See you in class.